Hello, everybody, and welcome to the webinar. This is Kathy Randall, and I am glad that you are with us this morning. And to those of you watching the recording, welcome. I guess I can give a really quick hello and a wave, and just say thanks again for being with us, and thanks for being a part of our how-to webinar series. And today we're going to dive into the topic of how to cool babies on transport. So I know a lot of you are interested in this, a lot of you are doing it, and so we'll just go ahead and get started. So I'm going to turn off my video. I just wanted to say hello, and if we have time for questions later, I'll come back on as well. So I have muted all of you, but you do have the ability to unmute yourself. So again, during the Q&A, we can do all of that. So just to keep the recording nice and clean, I'm going to turn off my video so that we have a nice clean screen for everybody to see. So I think first off, what I'd like to do is just say a big giant thank you to our webinar sponsors of MaxTech and International Biomedical, or Airborne, as many of us have known them as for many, many years. But they are actually a sponsor of, they were a platinum sponsor of our first conference, a Synapse Care conference we had in California and back in February. And as part of that, they got to sponsor one of the webinars. And so this one made the most sense for them. And so again, just a big thank you to them and for all that they do to support all of us in the NICU. So I guess a little bit about me and how I got interested in this topic. I have been a neonatal nurse for more than 23 years, I guess, if I do the math in my head. And I've just been kind of lucky that my career has taken me through many different situations where I was able to participate in research and education and new technology coming to market through my relationships with different medical device companies over the years, and have been an educator on AEEG, or amplitude integrated EEG, as well as cooling for over 10 years. And so when I took my position as a neuro NICU consultant at Stanford, we were just embarking on what we'll talk about in a little bit, which was the California Transport Cooling Trial. And so that was really one of my first up close and personal experiences with kind of what this field is evolving in. So without further ado, let's dive in, because you can see I have quite a lot of things to cover. So gonna do just a really, really fast overview on the incidence and impact of HIE, how cooling works. I think all of us are pretty familiar with that. And then we're gonna dive into the 3 ways that we can cool on transport, and then talk about some of the evidence that exists for servo-controlled cooling, and then give you some best practices for transport cooling for you to move forward and take back to your home units, or maybe just to validate that what you're doing in your unit is really working well. So just as a, again, really brief overview, the incidence of HIE, or hypoxic ischemic encephalopathy, worldwide ranges from 1 to 8 per 1,000 live births. So this is taking into consideration places like Zambia, where I've done education and training, where, you know, more up to 50% of neonates die. But if we're talking about where we live and where we probably practice, we're looking more like 1 to 2, or the average of that, obviously 1.5 per 1,000 live births. And one of the things I think that is really important for this topic today is an understanding that more than 50% of babies with HIE are not born in cooling centers. And although there are many factors as to why this happens, I think most of us can recognize that it's because we just don't know that these babies are going to happen. So there are some risk factors for HIE. There are some prenatal risk factors, there are antepartum risk factors, and then there are intrapartum risk factors. And I think probably most of us in the NICU don't really see much of these other situations, the prenatal and the antepartum stuff, but we're really the ones who get called when there is that stat C-section, that kid who's not doing well, or of course, if you're on the transport team, all of this has already happened and we're really there to mop up the pieces. So historically, for babies with HIE, we knew that about 1/3 of them would recover without disability. These are probably our mild babies. 1/3 would survive with disability. These are probably our moderate babies. And about 1/3 would die. That would be our severe babies. But with cooling, we really have changed some of these statistics, and we'll talk about that here in a second. So if we think about what this looks like here in the US, and I know that some of you are probably joining from Canada or South America, and so if we look at just at the US, where we have 4 million births per year, if we look at that incidence, that 1.5 per 1,000 live births, this equals about 1,200 deaths per year and about 1,800 disabled infants per year. So again, we know for those babies who have moderate encephalopathy, the associated risk of death is about 10%, and the risk of disability, again, is that 30% if they survive. If we're talking about severe encephalopathy, this is associated with about 60% risk of death, and most survivors will be disabled. So although we can break it down into that third, and third, we know that depending on your severity of injury, that you're going to have more or less problems. So again, I just want to briefly remind you, so when we're thinking, especially of those of you going out on transport calls, we do get calls for these kids who are labeled as HIE or who meet the clinical criteria for HIE. But I just want us to always keep in the back of our minds that there are a lot of fake outs with HIE too, and that there are babies who may present in that first, few hours of life, and even within that first day of life, who look like an HIE kiddo. But after everything gets kind of settled out and maybe we get some imaging at the end of cooling, there's oftentimes going to be other differentials or other possible diagnoses that pop up. And so just keep this in mind. We have to treat based on what we see, and we have to do for the baby the best we can. But oftentimes, and I know I can think of a couple of kids that we've cooled in the last year at Stanford where, the kids ended up having neuromuscular disease. Kid ended up having inborn errors of metabolism, but the kid presented in the moment as an HIE kid, so we cooled. But then when after cooling and the baby didn't quite perk up and things didn't quite look right, imaging turns out okay, then we start to have to go look for other causes. So just remembering that. And of course, we're talking about HIE today and cooling, but just to remember that there are these fake outs for kids who present like HIE. So let's talk just for a second about the pathophysiology, and it is a fascinating and ever-evolving pathophysiology of HIE. But what we know is that there are phases of this injury, and that there is an insult. Usually we can pretty closely define when that insult occurred. And then there is some amount of resuscitation and reperfusion that occurs, and that's based on our successful resuscitation of the baby. And within about 30 minutes to 1 hour, there begins a cascade of events that can begin to cause damage to the brain, even as it's starting to recover. And so there are 3 phases, and you can see them labeled here, but they're latent, secondary, and tertiary. And so one of the cool things about HIE is that because it is such a complex disease and there's so many things going on, there are many avenues for neuroprotection and intervention to be made. And so today we're going to talk really only about cooling, but know that there's a lot of really basic science and clinical research happening around some of these other pathways of injury in hopes that we can even improve outcomes further in the future. So the way I like to describe HIE is really focusing on those first 2 phases of injury. And so we can talk about this in terms of a hurricane like Hurricane Katrina, where the hurricane came in and caused an initial injury. And then we have so that caused, a lot of flooding and those kinds of things to start with and damaged the city of New Orleans. But it really wasn't until that secondary failure or the levees of the Ninth Ward breaking that the city really was devastated. And so we consider this similar to HIE, and what we want to do is prevent in HIE that continued damage. It's much like icing your ankle after you sprain it, but what we want to do is prevent that baby's brain from going from that latent phase into the secondary phase of energy failure. And so this is a nice little schematic that probably many of you have seen in previous lectures, where we talk about HIE and that primary energy failure, where the brain really makes its own decisions without intervention as to whether it's going to recover or whether it's going to be injured. And then there's this period, what they call that latent period, which we just saw in that previous slide, where this is that window in which things are beginning to rev up after reperfusion, where we believe the therapeutic window for intervention exists. And this is where cooling has really come into play, is in this latent period where we believe that we can stop this secondary energy failure and preventing that permanent and more extensive brain injury. So how do we know that cooling works? And so I'm going to just share just one animal study, and there are multiple, but this was done on fetal sheep. And what they showed were that that fetal sheep who had a planned ischemic injury, if they began cooling them within 90 minutes, they would have less neuronal loss and better functional outcomes. And this was really the kind of final straw that really helped us to move into human studies on cooling. And they also found that that some benefit was still maintained if we started cooling for these fetal sheep within 5.5 hours of injury, but there was no benefit if cooling was delayed until 8.5 hours after the injury. And so that really spurred then about a decade, it really was about a decade of clinical research looking for evidence to be able to do neonatal hypothermia for HIE. And so you can see here 7 of the first studies that were done in the years that they were concluded. And probably most of you are familiar with the CoolCap trial or the NICHG whole body trial done by Shankaran and the Neonatal Research Network. And probably the Toby trial. Those are kind of the 3, I think, that were the most known, and really you can see by the numbers too, really had the largest enrollments. You can see the Toby trial, that was the UK trial, that was 325, the NICHD had 208, and CoolCap had 234. You can see most of them were whole body cooling. There were 2 that looked at selective head cooling, or looking at the CoolCap. And you can see that most of them did term babies over 36 weeks. And there were 2 of them that looked at babies that were at least 35 weeks. And I want to bring this up because we'll talk about it later. But really, when we think about who should be cooled, we really want to stay in alignment with the trials. And that what you need to know from this giant list is that I think it was about 7 babies who were under 36 weeks were really included. So although the inclusion criteria, many people will state, well, the inclusion criteria were less than 35 weeks or equal to or greater than 35 weeks, really, there was only 7 babies of all of these trials that were under 36 weeks. The other thing is that 3 of these trials did transport cooling. And so this allows us to have some initial looks into the effectiveness of cooling on transport and to get some education for ourselves on how we should move forward. So this is a nice little overview of that. And then, of course, there have been several meta-analyses that have basically shown that hypothermia improves survival. So babies have less mortality, but they also show that these babies don't survive with additional disabilities, and that it does improve neurodevelopmental outcome in babies with moderate to severe HIE, and that the total number needed to treat is 7 to show benefit to 1. So in 2013, Dr. Jacobs did a Cochrane review and included 4 additional trials that had occurred from that first meta-analysis, and this included 1,505 babies, showing that hypothermia is beneficial, reducing mortality without increasing disability, and that the benefits of cooling outweigh the short-term adverse effects, and that it should be instituted in the term and the late preterm. I already gave you my little side note on that, with moderate to severe HIE, as long as they were identified before 6 hours of age. She also went on to say that further trials were needed. And so this would help us to know the appropriate techniques and timing of cooling, refine our patient selection. So really, should we be doing those late pretermers? Is it effective in cardiac arrest? The duration of cooling, which we've already seen, the optimizing cooling trial, which was longer and deeper, showed no improvement in outcome and actually increased rates of mortality, and we had to stop that trial. And also we need to still know if there's methods, improved methods for providing hypothermia, including the use of adjunctive therapies or other pharmaceuticals. So I just want to talk about a couple of the studies that have finished up, because I know some of you maybe are aware of them or maybe have questions about them. So late hypothermia. So the Neonatal Research Network from 2008 to 2014 enrolled babies in a study of late hypothermia. And this was a study that was looking at babies who were after that 6-hour window, but before 24 hours of age. And so Dr. Laptook at the PAS in San Francisco just back in May presented those results, as well as presented them at the Hot Topics meeting in DC last December. And the Bayesian analysis, which was their predefined statistical model, suggests a possible treatment benefit from cooling if it is started between 6 and 24 hours. There is a 77% likelihood of the reduction of death or disability, but it is inconclusive for larger effect sizes. So this means that they are not still quite sure of how well late hypothermia works. It did show that babies who were treated late did not have the same positive benefit that we typically see when we start before 6 hours, and that really they wanted to reemphasize that we should not delay efforts to recognize and start hypothermia within those 6 hours of birth, and more research is likely necessary to be able to say for sure, although this study that took almost 10 years to complete is likely to not be repeated. So they are going to do some post-analysis and maybe look at the data from some other ways, but at this point it's a little bit unclear whether or not it offers any major benefit. It does seem to not offer any additional harm, but again, not really offering any major benefits. Well, what about those preemies? So we all get those calls for those kids who are 35 and 5 or 35 and 2, and we wonder, should we, shouldn't we? Well, some of the studies showed we could. And so the Neonatal Research Network is currently enrolling a randomized controlled trial for preemies, and we're participating in that at Stanford, and looking at enrolling patients between 34 and 36 weeks so that we can really answer the question about whether or not there is benefit and whether or not there is potential for harm, since they are smaller. So that is currently enrolling, and they do safety reviews after every 20 kids or so, and we're already in the midst of I think we're up to 45 kids total in that study. The other things that we're looking at are adjunctive things like epogen, xenon, other kinds of things. And we're currently also enrolling through the amazing work of Yvonne Wu up at UCSF and UC San Francisco for the high-dose EPO for asphyxia and encephalopathy trial. And so epogen has actually been studied. It's already gone through several phase studies, and it's in the final stage now. And it's just interesting to look at hypothermia and its effect on HIE and see how similar epogen is for that. And so we're looking at whether or not epogen, high-dose epogen plus hypothermia can really add to the benefit that we see with that. So again, currently enrolling for this study, but more to come on that in the near future, let's hope. So where does this leave us? This leaves us with some recommendations by a variety of organizations, some of them international and some of them local for us here in the US. And basically what we want to see is hypothermia initiated still before that 6 hours of life. That baby should meet that trial criteria, and that the AAP's Committee on Fetus and Newborn in 2014 really emphasized the need for referral education of our referral centers so that we can identify hypothermia candidates early and very quickly. The other thing that the ILCOR statement in 2010 said is that, again, just reemphasizing that cooling is really beneficial for those babies with moderate to severe HIE, although many units may want to cool the more mild babies, since, you know, it doesn't really show any harm. It's really not consistent with the trial protocols to cool these mild babies. And so, although there is some prospective research being done on these babies as well, right now we really want to keep it to those moderate to severe, and especially those moderates, they really show the most benefit. So one of the things I wanted to bring up is part of the TOBY trial. So remember, that was one of the trials that was initially done, and it's actually was done all in the UK, and they actually did do transport cooling in this particular study, which is particularly why I wanted to bring it up. They showed that infants in their study who were cooled by 4 hours of age, so again, they were cooling on transport, so they could really get these kids started fast. They showed a trend towards improved outcome. It wasn't statistically significant, so they couldn't say for sure that that by cooling sooner, it improved outcome, but we are certainly seeing a trend towards that, and it's always important to remember that time is brain. Another important factor I want you to know about is, especially with some of the animal research that's been done, is that latency period may be inversely proportional to severity of injury. So what does this mean? So what this means is that that therapeutic window might be actually shorter for the most affected neonates. So yes, we should try to do our, get our babies cooled by 6 hours, but for those babies who are the most severe, we should be trying to get them cooled as quick as possible, for this very possibility that it could actually be that their therapeutic window could actually be shorter. So their window could actually be closer to that 2 hours or that 90 minutes that we saw in the sheep study. So then, with all that background said, let's talk now about cooling specifically on transport. And why is cooling on transport so important? Well, studies have shown that 45 to 78% of babies in need of cooling are not born in cooling centers. And so what this means is that we need to find ways to be able to get their cooling started quicker. So the randomized control studies, the ones that we've just gone through, showed that babies who were outborn, so of course, when they were doing the studies originally, right, there weren't as many cooling centers as there are now. And so, most babies had to be, transported to the centers. And so what these studies showed then were that babies who were outborn had a delay of up to 1 hour in initiating cooling therapy as compared to those babies who are inborn. And that makes sense, right? We have to get to them and we have to, assess them. That ended up having they were older at the time of first getting to their target temperature. They had more severe encephalopathy. So again, that time is brain. Do we really want to wait if they are more severe when they're outborn, which makes sense, right? They were, probably a low risk delivery, and they were out in a community center. Excuse me. And then in the end, at outcomes, these babies who were outborn had lower motor development indexes or motor development scores. So again, we want to make sure that we are getting these babies taken care of as quickly as possible. Oops, my screen just froze. Just one sec. Okay, let's see here. All right, so what does this mean then for us cooling on transport? Number one, we need to remind ourselves that there is, even with the current evidence, that there really is that small therapeutic window. And even though we know that some research has been done around that later cooling, that we know it doesn't work as well as our early cooling did. And that there can oftentimes be long distances between the birth center and the cooling system, center, and that oftentimes our babies who are coming to us for cooling on transport have had late recognition. They had kind of a slow start, but then they perked up, but then they started seizing. And so there is a late referral for cooling. So once we're actually on our way, we may actually be pretty close to that 6-hour window. So when it comes to transport or community-based cooling, there are really 3 ways that we can cool. So there's passive, there's active, and there's servo-controlled. So for passive cooling, we're basically talking about turning the bed off. So we are looking for removing all of the sources of heat. So turn the bed off, remove all sources of heat, and then remove all the blankets. So the baby's basically laying naked with just their diaper on the table. Well, this may be fine, but what we found when babies are passively cooled, either in the community or during transport, so if we just turned the transport incubator off, or if the baby was resuscitated in the delivery room without any radiant warmer, the temperature drops, and although we would think that it would drop very rapidly, compared to active cooling, it actually drops more slowly, which means it takes longer to actually reach that target core temp. And this means that we have a later start time to the therapeutic effect. One of the biggest risks for this passive cooling is overcooling, and that's getting babies below 32 degrees C. This is especially true for babies who have more severe HIE. So babies who have more severe injury tend to overcool themselves. So when we remove all heat sources and we turn off their beds, they have a very, very high likelihood that they are going to overcool. And so some data shows that somewhere between up to 1/3 of babies who use passive cooling methods are overcooled. And that, of course, has its own risks, right? More bradycardia, more bleeding problems, more of the complications that we know of. Passive cooling also really requires more staff manipulation, because the baby's going to get potentially overcooled, and then you have to intervene to get them back in range. And then once they've been out of range, they're really complicated to get back in range. So really takes more time in the long run. The other thing is that there's more variability of these temperatures as well. So even when rectal temperatures are used, you see more variability. Again, there's that more fluctuation, more rebounding, overshoot, undershoot, and just not keeping the baby in that tight therapeutic window. And then what this results in is just less time overall in their target temp. And that is really the temperature. The body temperature is really the therapy. And so we want to keep the babies in that range. So what are some of our options then if passive cooling didn't work, or the baby's just not cooling off, which we saw that there's sometimes these babies who are very slow, then active or manually controlled ways of cooling were then used. And so many of the studies, the ICE trial and the ICER trial, both used gel packs and ice packs for this. And so kind of like this guy here in the freezer, hugging up on ice packs, they showed that the ice packs were actually even more cold than the gel packs. So if you think about kind of a bag of ice versus kind of a chemical cooler thing that you might use, that you might throw in your freezer and use over and over, the gel packs are actually a little less cold. And so they found that the ice packs actually were more difficult to control. Some units, especially units in low resource areas, excuse me one sec, used fans, and they found that although it could work for a little while, it was really, really time consuming to make it work. So fans are not really ideal. And then there are, of course, the very early historic studies of using water baths. And so those are not used really today, but really historically, these are things that people tried. This is actually a picture of a transport nurse in the ICE trial that was happening in Australia and New Zealand and Canada. And you can see laid across the baby's chest here and behind the baby's neck. You can kind of see my little cursor there moving. You can see these cooled gel packs that they would actually use to manually bring down the baby's temperature. And so they would continuously monitor the baby's temperature using a rectal probe. They would be checking axillary temps every 15 minutes, but they would really just be using these packs on and off, just trying to get the baby's core temperature to the place it needs to be. So what are some of these downsides and some of these risks? Well, of course, with passive and active non-servo kinds of options, for the passive side, we have over and under cooling. We really do lose our ability to continuously monitor that baby if we turn the bed off completely. And I have some suggestions about that later. And then, of course, with the active non-servo cooling, it's constant staff manipulation, needing to check the temp, add a pack, decrease a pack. And then, of course, these ice packs had some risk for skin injury from ice burns. So really, in the end, how did this play out in clinical practice? Well, in California, we have the California Perinatal Quality Care Consortium, or the CPQCC. And in collaboration with them and our California Transport Department transportation system, we were able to actually look back for the year of 2010 and see how babies fared during cooling, active and passive cooling on transport. And what our study revealed when we did this review is that very few babies were actually inside that target range. We ended up with about 44% at target, about 43% above target, and again, that risk of overcooling was about 13%. And so these numbers are pretty consistent around the globe when we look at passive cooling or even active with ice packs during cooling. This is pretty much what we get when we use non-servoed devices or methods. This is another study, showed very similar kinds of things. You can see, again, the therapeutic range, even when you widen the therapeutic range from 33 to 35. So leaving that there in the middle, you still see that a fair number of babies are over that, and that there's, again, numbers of babies who are undercooled. And this is looking at babies on the time of transport. So then they would do passive cooling during transport, arrival at the cooling center, and then active cooling beginning in their home unit. So you can see that for many babies, the passive cooling worked, but it took them down further than we wanted. For some babies, it just didn't even work at all, and they never were in the therapeutic range until they started their active cooling at their hospitals. And so that can be hours and hours from when the insult occurred. So then this leaves us with kind of that third way, which is really active cooling, but using a servo-controlled device. And what's nice about these systems is that they're automated. They have a set point that regulates the action of the system up and down to keep the baby really in that sweet spot that we're looking for. Currently on the market, there are really two servo-controlled devices that have been used in the literature for a neonatal cooling on transport. We have the Ticotherm Neo, which is about 7 kilos, and then we have the Criticool, which is about 77 kilos. And so for those of us in transport, that is important because sometimes we have limitations based on what our rigs can hold and what our flight partners will allow for us. And so definitely having an option that is smaller is definitely been really helpful and has been really well tested throughout the world. But both these devices you will find in the literature and utilized with similar results as far as effectiveness on cooling the baby to the core temperature that we desire. So I thought what I'd do is show a couple of those research studies that have been done, really looking at how well do servo devices work. And so whether or not using a servo device is really worth the money and whether or not it is actually as effective as we think. So you can see here that this is a group from Sweden. They actually use the Criticool, and you'll see that upon team arrival, if we look up here at the top part and table A. So on arrival, these were hospitals that were passively cooling babies to start with. And so some of them had gotten overcooled and some of them not so much. So we have here, they were in a wide range, some of them above 37, some of them trending towards our therapeutic range. And then they put the baby on the Criticool when they got there. And you can see at the departure that these babies were getting closer to the target, if not all of them were in target range, and then remained that way until they were at their cooling center. This was one baby whose set point was actually increased due to cardiovascular collapse, and so they reversed cooling for that one baby, but he's included for there. Same with down here, he's a little dashed line. Again, you can see time from servo-controlled cooling to reach that target temp, and that's in section B down here. And you can see team's arrival in that first section here. And then you can see pretty rapidly, around 45 minutes, these kids are really pretty much all in range and remain there throughout. So another study that was done in the UK actually looked at comparing passively cooled to actively cooled babies. And so they were showing, and this was actively cooled using a servo-controlled device. You can see that upon arrival, that's these first two little scatter plots here, or box plots here. You can see the range of temperature. These are babies who were being passively cooled by the referral hospital. You can see that these temperatures don't really vary very much. But once we start getting on departure, so as soon as they arrive, they put the baby on a Ticotherm. You can see that the babies are getting much closer to their target. Those are the light blue box plot here, and the range is much smaller. And then, of course, upon arrival to their facility, you can see that the babies who were passively cooled had still a very wide plot of temperatures, and trending towards being more in the middle, but 27% did not achieve target temp. And you can see 34% in this study were overcooled, whereas you can see for the servo-controlled babies, most of them within that tight range, and no babies overcooled, and maybe one just still hanging here above. So you can definitely see that active cooling using a servo-controlled device gives us much tighter control and much quicker. And then we have the study that was completed here in California, the California Transport Cooling Trial. This was 9 hospitals who randomized babies to standard of care, which was passive or active with gel packs, or to a servo-controlled device for cooling. And this is still only the only randomized control trial that's been done comparing active to passive cooling. So what we found in this study was that the babies who were in the servo-controlled arm were much quicker into their target temp and stayed there. And then you can see for the passive babies, or the standard of care babies, or the ones who had non-servoed gel packs, they did not really achieve their target temp very regularly. And they definitely, you can see many of the lines are very wiggly, and some of them would come in and out and under and up, and many of them even just never reaching target temp at all. The primary outcomes and secondary outcomes of this study were all statistically significant. And first, our primary outcome was that the temperature was in target range during transport. So the percentage of time that the baby stayed in target range. And so for the device, it was 71%, and the standard of care was 0%. And that was statistically significant. And the secondary outcome of subjects being in target range by 1 hour, again, 72% versus 20%. So again, that time is brain, getting those babies on the blanket and cooled quickly. And having them within target temperature anytime during transport, 80% for the device and 49% for standard. So that was whether or not they hit ever. And then I think one of the, again, important things is that time to target temp, 44 versus 63 minutes. Again, time is brain. We want these kids to really be in that target temperature as quick as possible. So really the conclusion of that randomized controlled trial was that servo-regulated cooling improves temperature regulation during transport. So again, what are those benefits then of servo-controlled cooling? First, shorter time to target temp. Time is brain. Less variability. So staying within the therapeutic range is basically like if you're trying to give an antibiotic and not having it bounce all over into non-therapeutic ranges, you want your treatment to be in that therapeutic range as much as possible. So that less variability is important. And so being able to do that and to have it require less manipulation by staff is really another important benefit. And one study in the UK actually showed that because they believed that with a servo-controlled device, they could attend to the other stabilization tasks, they were actually able to turn around their transport time actually faster when they used a servo-controlled device. They could put the baby on the mattress, they could continue with other activities knowing the device is doing the work, and it was up to an hour, I believe, that they were able to shave off of their transport time. So of course, with our transport teams, we want them back in-house as quickly and as safely as possible. And so being able to utilize a device to do that is really critical. So all that said, is passive cooling still a good option? So if you don't have active cooling servo-controlled devices, is it still a good idea to do passive cooling? So there are some situations that I think where you can improve its safety and be able to use it. First off, I think if you're doing extremely short transports where you really don't have that much time anyways to get things going, and you can just quickly get the baby back home to your home base and get them on their standard cooling, I think that passive cooling might be still a good option then, especially if you're using fixed protocols, because again, you saw how inconsistent passive cooling and how dangerous it can be, these overcooling. So if you have a fixed protocol to ensure safety and consistency, then I think passive cooling can be used and has been demonstrated by others to be safe. An audit, if you're doing regular audits, just to make sure that things are following along and that your babies are getting and staying in target range. I mean, I think if you take a really careful approach to it, then you can safely do it. Of course, if your helicopter, your ambulance, or whatever transport system you have is not able to accommodate the weight of your device, then of course I think doing something is still better than nothing, and just being really cautious to that. The other is if you do too few cases, if you're only doing 1 or 2 transports a year and you're only using your cooling device, then maybe you can't justify the cost to keep up your team training and to purchase that device. But I do want to caution against passive cooling. I think that the literature clearly demonstrates that it's not very safe and there's a lot of risks to it. But I can appreciate there could be certain situations, especially in low resource areas, where passive cooling is still an option that's better than nothing. So then what are our best practices? So to wrap this up with things that you can take back to your unit and to think about what you want to do, and maybe just again to confirm that you guys are on the right track with your transport cooling program. I think it's important to recognize that the transport environment is unique. Oftentimes we might have difficulty controlling that ambient, that ambient temperature, and we want to make sure that we are at least controlling for that. There was a study done in Finland and in Sweden where they looked at really cold days and whether or not babies were more out of range. And it didn't show that there was really any difficulty with that at all. But, we do want to be aware that we are in these other, we have other environmental factors. Sometimes there are lack of heated and humidified gases on transport ventilators. And so in addition to offering, especially if you're offering passive cooling and you're not providing any humidified gas, you may be actually cooling the baby even more. So making sure that you use those when they're available, advocating for the addition of those whenever possible. Also just saying that we're adding extra devices to our transport setup, and that we need to make sure that those are secured well, they're crash tested, and that everything is up to national safety standards before we add extra weight and extra devices to our rigs. Weight can be a serious issue and really preclude the ability to use these devices on transport. And knowing that all the commercially available devices for cooling don't have battery power, and so you might either have to get a universal power supply or just make sure that you have ability to plug in during the duration of your transport, especially for really long transports, or having the device is really of no value. So all that said, there really are no evidence-based guidelines that have yet been published for cooling on transport, but there are some toolkits that I found online and that have been helpful in our practice here in California that I thought I would at least share with you, and I found them really interesting, so thought I would just mention them to you. The first is from the UK, from the NHS, or the National Health System, and they have a website called the BBOP, which is the Baby Brain Protection Program. And I'm going to share some of their slides with you. And then the California Quality Care Consortium, the CPQCC, we've published a toolkit here in California, which is available for download for free online as well. So I think no matter what, outreach is really important, and really establishing a great working relationship with our referral network, educating our community providers. One study I was looking at was showing that they did 690 people over like 52 different educational opportunities in 2 years to make sure that the community is aware of what babies are eligible, who to call, when to call, and really how to safely take care of these babies till the transport team can get there. The other piece of that outreach is really creating parent education materials. And so I'll show you a few examples of those that I found online. So again, this is from the BBOP website, and I thought this was great. They had this neuroprotection care pathway, and they provided this for their referral centers. Now remember, the NHS in UK is a socialized medical system, and so they have a little bit more consistency and control. But for those of you who practice in systems, these are things that you could easily do. And if you're more of a community-based or academic setting, we have to work a little harder for some of these things to be consistent. But for those of you who have the luxury of being in systems, much like the NHS is, you can implement a lot of these things much, much easier. So they basically gave an algorithm, and I hope that it shows up at least to some degree, where you can say, do you need to cool? And then basically just walking the community provider down the pathway and giving them opportunities to be able to document times and when they've called and what decisions have been made all along the way. So I love this little easy to follow worksheet. In the CPQCC toolkit, we have something similar to this as well. And so, I encourage you to look at that as well if you'd like. The other really important thing, I think after talking about passive cooling on transport, I think it goes without saying that we really need to have solid education around what is appropriate passive cooling for our community centers. And so this is basically a great algorithm. It's just an image that you could download and to use and to share, that you can basically walk someone through how to maintain a baby within that target temp. There is some encouragements about community centers, maybe not aiming so closely to 33.5, but maybe aiming more towards 34.5 or 35. So maybe trying to prevent overshoot when a hospital's kind of new at doing passive cooling. But I think having really great communication and education up front about what to do for babies who are not reaching target temp or whatever your established protocol is. In the guideline that I wrote for NAN back in 2008, I recommended for passive cooling to shoot more for 34.5 to 35 until the team arrived with their ability to manage the baby a little bit more. So just trying to prevent that overshoot and overcooling. So again, I think just education around passive cooling is so important. The other thing I want to encourage is this idea about turning the bed off. Well, we can leave beds on in manual mode and change the set point if it's in manual, you basically control the heater, right? So this is a manually controlled bed. And so we don't have to turn beds off, especially if they're in radiant warmers, to be able to manage a baby passively. So either you can set your baby temp at that 35 skin temp, or you could actually change your device to the manual mode and just turn your power to 0% heater. And so I think this is a really important distinction, especially if you're doing community teaching, is there was just this initial trend on this passive cooling was just turn the beds off. Well, I think the thing that we miss out on when we do this is that we lose the ability to continuously monitor anything. If you can do core temperature, that's great, but at least do axillary or skin temp so that you can keep an eye on a baby as they are going through passive cooling. So I really do advocate for not turning the bed off, just turning the bed to 0% power or servo controlling an open warmer at a very low set point. Just remembering that axillary temperatures can be 1 to 1.5 degrees less than your core. So a baby who has a core temperature of 33 may have a skin temp of 31.5. And so you want to make sure that you're kind of keeping that in mind as well, which is the other reason why I advocate for community providers to kind of servo control a baby at a little bit of a higher than target temp, because I feel like we can get ourselves behind the 8 ball pretty fast. This is a great handout that is put together again by the Bebop group. It's a HIE information for parents. UCSF puts out a great one online. I know Johns Hopkins in Maryland has a great one. And if you email some of those providers, they'll share them with you. But I just think it's important that we have information for parents. I'm teaching them about cooling and how important that is as an intervention for their babies. Of course, we need training, and we need training for our teams, our transport teams. I think creating care pathways and protocols really help, giving us checklists and things to use. We need to keep on top of our cooling devices. Again, just like inside the unit, we may not cool babies very often. And so making sure that everyone stays comfortable doing troubleshooting drills, and that you're doing regular audits to be sure that you're keeping up on how you guys are doing with your practice. There's always ongoing research. So I think it's important, excuse me, to be able to know when we should be cooling and when we should not be. So what about those checklists and those protocols? Well, there are so many of them already, but I think it's important that we use them for this as well. And I just wanted to share again from the Bebop group. This is a part of their pathway that they had shown, and then just has for pre-transport, for at the referring unit or at the birth hospital, things to do, things to check off, really simple and just easy to use. I thought it was really great the way they had created this. And also just in transport, what are the things to be looking for? And once you're back at your home base, what are the things to do? And then just reminding ourselves how important the parents are, making sure that we're giving all of them good information, and that we're completing all of the documentation for ensuring that we're keeping the baby within range. And I love just the ease of use of this form, and just all the good time points that would allow us to do good quality improvement work. Things to look for in transit, things to be doing at the receiving unit, things to be doing back at base. And of course, it's always about safety. And I think that it's important that we think about that safety of equipment, which I mentioned earlier, but also for the patient. These are some great pictures from a couple different studies that showed just ways that people had secured the Ticotherm device. And I thought that was really, really good examples of ways to do this and to keep things looking great. The other thing that the Bebop group has is a rectal temperature monitoring chart. So maybe you're using esophageal temperature probes, or maybe you're doing something else, but a core temperature. I thought this was great because it actually had the time of cooling, when cooling began, and then what the temperature trend was. So you could kind of plot it out on this little chart, which I thought was a really great idea. They also had a temperature log that you could use. having all the different set points, the readings, the skin temperatures, rectal temperatures, and any actions that were taken. And I think it's really important that we do these ongoing audits. And if we don't have good documentation, it makes audits almost impossible. And that really is the best way that we can ensure safety. And we really want to make sure that we're not deviating from our protocols, that we can identify areas of our own team's strengths and weaknesses, and to make a plan to strategically improve the care we provide. Anytime that we implement a new change in practice, we have the opportunity to do three things. We have the opportunity to either underuse a therapy that works. So by not offering infants to all infants who have moderate or severe HIE, for not cooling them within the proper time. If we're not getting to these babies, we're not identifying them, then we might underuse this extremely powerful treatment. Sometimes we overuse good treatments. We have good intentions, and we decide that, you know, we offer cooling to kids who don't exactly meet criteria. And so we want to make sure that we're not doing that as well. And then we sometimes can misuse therapies. And so I think without doing quality, we won't be able to identify if we're falling into any of these three traps. And they're really easy to do when we, you know, we get busy and, you know, things just become part of our culture. This is just a very long list, so I apologize for so many bullets, of just some ideas of things that you could audit in your unit or during your transport practice. So did babies meet the hypothermia criteria? What was the time to target temp? What was the incidence of out of range temperatures? You know, was the baby admitted into a neuro NICU? Did you offer neuro consults? Were there any adverse side effects? And if you're looking at your kind of full program, if you're based in a hospital, maybe you're looking at whether or not your MRI was done between X and Y date. So I think there's a lot of different components. There's a lot of moving parts when it comes to a transport cooling program or just an inpatient cooling program. And so there's a lot of opportunity to be looking for what we're doing. So to wrap up, I just want to offer these kind of final thoughts that hypothermia really is currently our only proven treatment for infants with HIE. The time window for therapeutic effect is short, and that servo-controlled devices offer the safest, the quickest, and the least time-consuming ways to offer cooling on transport, and remembering that time is brain. I think transport, as we all know, poses unique considerations, but early initiation of cooling before admission to the NICU is essential for our best outcomes. We recognize that 50% of these babies are born outside. They're outborn babies. And so we want to make sure that we have great practices to do this. And cooling on transport has been proven through the randomized control trials and through other retrospective trials to be safe and to be effective. But it needs to be done by trained teams, and it needs to be done using a servo-controlled device whenever possible. And that's the best way that we can ensure the best outcomes for our babies. Because again, we don't want them to not be in that therapeutic range. That is the therapy, and so they need to be there as much as possible. With that, I found this great picture. All my pictures are from Google. I should have disclosed that up front. I found this great picture. I thought it was fantastic. Somebody in the 70s doing a transport with their tab soda. I thought this was great. So anyways, there's a long list of references to consider. And again, I just want to say thank you to our sponsors and really thank you for being here and for all that you do for caring for our babies. So, so with that, I will wrap it up. And if you have any questions, you can either unmute yourself or you can type them in the chat area. Anyone?